Clearly there's a role for all of these drugs. I mean, they've all been shown to improve overall survival, so I think it's important that we use them all in a smart manner. And so to date, we've used them individually, and I think the standard of care is still to use them sort of until progression and then use the next one, whether it be first a BRAF inhibitor, then immunotherapy, or immunotherapy and then BRAF inhibitor. We don't truly know which of those is the best approach. There are some phase 1 clinical trials that are now starting to be reported in which all these drugs are being given at once, so BRAF and MEK inhibitors plus PD-1 antibody or PD-L1 antibody. The rationale for doing those is not totally clear. It's more we just kind of have these drugs, so let's give them all at once. But these are the questions we need to sort out. And I think, again, with sort of this multi-dimensional biomarker analysis we've been talking about, we'll be able to eventually hone in on which patients will derive the most benefit. I will note there is some concern that as we're starting to study resistance in patients, unfortunately we're starting to find some overlapping phenotypes between targeted therapy and immunotherapy. And that's a little bit disconcerting because that could suggest that the patients most likely to benefit from targeted therapy are the same as those who are likely to benefit from immunotherapy, and that if we give them all at once and get resistance, we might be resistant to everything. So we don't know that answer yet, and that's where the research is really going to go in the near-term future, but this is why there's still a lot to do in melanoma and why we really still need patients participating in clinical trials.